Let's start again with the microphone. Oh. Sorry about that. In any event, we were supposed to have a visiting professor today who was going to talk about renin-angiotensin and aldosterone system and high blood pressure. And that certainly is not within my lexicon to talk about intelligently. So I quickly put together something in an area which I've given grand rounds previously elsewhere, on a very interesting topic, Klinefelter Syndrome, a very common cause of primary gonadal failure, which occurs in about 1 in 500 to 550 men, so that all of you know someone with Klinefelter Syndrome. Many of the patients go undetected, and perhaps the person you know with Klinefelter Syndrome is one of those who's undetected. So I tend to always start my talks with a little case, a patient who I've seen, to put it in context. So we have this 20-year-old man I saw a couple of years ago now. He was referred by his pediatrician because he had a carbuncle in the groin area, and he finally had an exam of that area, which showed small testes. As a baby, he had a patent ductus arteriosus, and it was repaired. And he's followed yearly by cardiologists with echocardiograms for a partial anomalous pulmonary venous return. He went to high school and graduated with a B average, and he was much better in math than in reading comprehension. And he has always been really quite withdrawn with a few friends. He did attend the U of L. He majored in business. He had some difficulty dealing with the coursework at school, though. And he was also working in a supermarket, and he subsequently did graduate. He told me that he shaved his beard at age 14, not so much different than his friends, but he only shaved every couple of days. And he had a little bit of chest hair, and his chest hair and facial hair was much less than his father and his brother. I mean, men have a wide variety of chest hair and facial hair. So you want to put them in context with a sibling or parent to see, to better understand it. He's 6 foot 1 inch tall, and he's the tallest member of his family. Dad's 5'10", mother's 5'6", and his brother's 5'9". And he's quite thin, with an unusually long face. He had no thyromegaly. He had bilateral breast enlargement. His testes are both quite small, 2.3 centimeters in length, which is 3 or 4 mLs with a orchidometer, which I'll show you. His phallus was probably normal, 6 centimeters long, but it had 2 meatal openings. The dorsal opening was a little shallow pit. And the opening on the slightly ventral surface of the glands was the urinary channel. His testosterone level was normal, 316 nanograms per deciliter, but his LH and FSH concentrations were quite high, 36 and 66 units per liter. The SHBG was normal, and non-SHBG testosterone was on the low side as well. And ultimately then he had a karyotype, which confirmed the diagnosis of Klinefelter Syndrome. So, in keeping with Jesse's interest in the history of medicine, one of the reasons that I chose to discuss this today is that the paper which described Klinefelter syndrome was published just about 75 years ago, and therefore Klinefelter's at 75 is the title of my talk. The other reason to discuss it is the emphasis on residents and fellows and students to get involved in research. And as it turns out, Dr. Klinefelter had just finished his internal medicine residency at Johns Hopkins and was looking for some additional training. There really weren't any formal fellowships at that time. And he decided to go to the Massachusetts General Hospital to work in what's called the Thorndike Research Lab, which was a precursor of the clinical research units, which now we know is the CTSA. And he hooked up with the head of that unit, a man known as Fuller Albright, who was the head of the unit and the head of endocrinology at the MGH, purportedly one of the very smartest academicians ever. And a lot of people have written that Dr. Albright had more interesting and exciting ideas in one day than most of us academicians have in our entire career. Well, Dr. Klinefelter is now just finished his residency, and he's seeing patients in the clinic who were referred to Dr. Albright. And he sees this man with breast enlargement and small testes. And he says, okay, here's what I found, Dr. Albright. What's the matter with him? And Dr. Albright says, I don't know. I really don't know what's the matter with him. And what happened then is, because of the breast enlargement, Dr. Albright called his nearby Boston colleagues and all the surrounding Northeast to see patients with breast enlargement. And you can imagine they probably had 100 overweight men with breast enlargement, but among them, they found 7 men who had small testes and breast enlargement, and that's the basis of the Klinefelter Syndrome. And Dr. Klinefelter wrote that he was quite amazed that Dr. Albright allowed it to be called Klinefelter Syndrome, because he was just doing the legwork, and Dr. Albright, of course, was all of the ideas. Dr. Klinefelter, when he finished his work at the MGH, went back to Johns Hopkins and was a rheumatologist. And he was on the clinical rheumatology faculty at Hopkins until 1990, when he passed away. Dr. Reifenstein was a medical student who was spending some time during his career in the Thorndike as well. And he ultimately had a syndrome named after him. Reifenstein syndrome is a type of androgen resistance, where type of testicular feminization, partial androgen sensitivity, used to be called Reifenstein syndrome. He went on to be an endocrinologist, and he practiced at the New York Medical College and also worked at SWIB. And he was instrumental in developing oral contraceptives during his career. So they wrote in their paper, the syndrome under discussion begins during adolescence and is characterized by gynecomastia and a very specific type of hypogonadism. The latter is almost entirely in respect to the function of the tubular tissue, that is the sperm-forming cells, the germinal epithelium and Sertoli cells, while the function of the Leydig cells, the growth of the phallus, prostate, and sexual hair remains relatively normal. So the men didn't have ambiguous genitalia. Thus one finds bilateral gynecomastia, small testes, aspermatogenesis, so they were azoospermic, evidence of normal to moderately reduced function of the Leydig cells, increased excretion of FSH, which they assayed with a urinary assay based on injection of material into mice, and usually reduced excretion of 17-phenylsteroids, which was a way to measure androgens in the urine at that time. So in the paper is a big picture of all the patients. We don't see too much of this any longer, but you can see the breast enlargement, which of course was the reason that the men were referred for the study. And you can see that they look somewhat hypogonadal with less amounts of body hair. You can also see that they're quite tall, especially with very long legs. And you can see that they have relatively normal amounts of pubic hair and a normal genitalia, but you can get a sense that the scrotum is quite small. So in their picture, Dr. Klinefelter drew this schema of what negative feedback would be like. I'm sure Dr. Albright really drew it. But this is what they thought is normal. They didn't have any idea that the brain controlled the pituitary at the time. And they looked at the negative feedback and positive feedback between the pituitary and the testes. And this is normal. And they knew that there were 2 different negative feedback components. One was testosterone coming from the Leydig cells, and the other was something coming from the seminiferous tubules. And they have the arrow going to LH, but really it should go to FSH. And they knew that the Leydig cells were making up male hormones, which caused the scrotum and other male features to develop. And they thought also that the testes made a hormone which stimulated the breast. And then they found, they hypothesized that when the testes were removed, these positive signals were low, and therefore there was negative feedback. And they already knew that pituitary cells were markedly enlarged in castrates. And in their syndrome, they proposed that there was a substance produced by the Leydig cells which was responsible for the gynecomastia, and that's what they were looking for. And they wrote that one is left with the conclusion that the lesion is the degenerative one of unknown etiology starting early in life. So it stood this way until 1994, when Dr. Barr, an anatomist, realized that there was condensed chromatin on the edges of nuclei when you have an XX chromosome constitution, and they call that the bar body. And this is sort of degenerative or deactivated DNA. And the significance of that remained to be determined until the chromosome analysis was ultimately identified. And finally, in a letter to the editor, Dr. Bradbury, an endocrinologist and geneticist in Utah, had a patient who had the phenotypic features of Klinefelter syndrome and performed a peripheral blood karyotype and found that there were 47 chromosomes. Not only was there a small y and an x as in a normal male, but there was a supernumerary additional x as shown there. So how does this come about? It comes about by non-disjunctions during meiosis, and it can happen paternal origin, the sperm, or in the egg, and about 50-50 account for the pathogenesis of Klinefelter syndrome. So what happens if you have a non-disjunction then? You wind up with a sperm which has an extra chromosome. So when you have a 46XY duplicating, you have a 22 cell line which dies. And then you have a 24 cell line with both the X and the Y. And if that 24XY cell line combines with a normal egg, then you have a gamete which is 47XXY. And if that were to occur in the maternal, there are two sequential cell divisions, and basically the same thing. You wind up with an ovum with an extra X, 24XX, 24XX, and a normal sperm comes along, and you have then 47XXY. Rarely you can have a post-zygotic non-disjunction where the cells have already been fertilized, have a normal 46XY, and you wind up with a 45Y cell line, which is non-viable, and a 47XXY. And it's probably this which accounts for all the mosaicism, which I'll show you. So the prevalence, I told you, of Klinefelter syndrome is roughly about 1 in 500. But the prevalence based on doing surveillance karyotypes is much, much higher. This is from Denmark, where they routinely do genetic exams on newborns. And this represents the prevalence of Klinefelter syndrome on 160,000 prenatal karyotypes and 40,000 postnatal karyotypes. So you can see that the prevalence is anywhere from 100 to 100,000, so 1 in 1,000 when the moms are 24 years old, way up to almost 5 in 1,000 when the moms are older. And you can see then that older moms are more likely to have babies with Klinefelter syndrome. And you can see that when the karyotype is determined when the patients present clinically, the prevalence is much lower than when you estimate the prevalence of the disease based on the surveillance. So you can see that all of these men, between this one and this one, are all men with Klinefelter syndrome who were undetected, in a way. So one of the ways that patients with Klinefelter present is having just no sperm. So if you look at the prevalence among men who have no sperm, you can see that among those men, about 8% have Klinefelter syndrome. Most have an XXY chromosome constitution, and a few have a mosaic constitution. The most common reason for non-obstructive anospermia turns out to be microdeletions in the chromosome the area which codes for the AZF, the sperm-forming element genes on the Y chromosome. So these are microdeletions rather than the major aneuploidy of XXY, the most common reason for this. And if you just look for infertile men with low sperm count, the chances of finding Klinefelter syndrome is much, much less. Here's another study with prenatal and postnatal detection. You can see the vast majority of men with the Klinefelter phenotype have the 46XY constitution. About 10% have mosaic cell patterns, and some men have multiple X's. These men frequently have mental retardation and a tremendous abnormal phenotype. Now, one interesting type of the Klinefelter syndrome is men who have the same clinical features who I was talking about, but when you do a karyotype, you find it to be 46XX. And I saw a patient like this last year. I was going to present him, but I thought it was a little unusual, so I didn't use him as an index case. So these individuals, unlike the Klinefelter's patients, are not tall, and they are more likely to have breast enlargement and more likely to have cryptorchidism. They do have testosterone levels which are on the low side. They have gonadotropin levels which are quite high. They have very small testes, and much like the Klinefelter's patients. So you really can't tell these patients until you begin to do a karyotype, and it's always quite surprising when you get a 46XX and it's a male. So how does that come about? Well, normally when you get chromosome replication, the sister chromatids divide and multiply here, and then they join, and then ultimately they divide. And during this time, you can often have a little bit of crossing over between the chromosomes of maternal and paternal origin. So you can see there's a little bit of blue here and a little bit of orange here. It's just a schema. So if the same thing can happen with the sex chromosomes. The X and the Y are very, very different, of course. One is a little tiny chromosome with 100 genes, and one is a big chromosome with over 1,000 genes. But nevertheless, both of them have a region which is similar, and it's called the pseudo-autosomal region. So that means that the genes here are quite similar, so they can pair up like this, and you can get some crossing over because those two chromosomes share the DNA. Now, right near the pseudo-autosomal region are the genes which code for the testis. So you can imagine then, if you happen to get a little bit of crossing over, you can have a transfer of this Y material from the SRY, the testis-coding genes, from the Y chromosome to the X. And that will result in a person with an XX chromosome constitution who is phenotypically male. And you can imagine just the opposite. That is, if the SRY winds instead over on the X chromosome, then you have an XY individual looking female. So you can detect this very simply by having a cDNA with a fluorescent probe, and you can just do some cheek epithelium, and you can see there's a little very bright spot here, and that shows the fluorescence detection of the Y chromosomal material in these cells, even though the cells karyotype XX. Of course, you can do PCR and be a lot fancier, but this is what you'll find in clinical medicine. It's used in the IVF programs, and it's used in screening for people who have genetic abnormalities. So that Y determining gene, the SRY then, what if it's disrupted? What if a little bit of it is removed and not all of it is transferred to one chromosome of the other? Then you can have a testis which only functions partially. And the fetal testis has two jobs. One, to make male hormones, which cause the external genitalia, and the other is to make something called Müllerian inhibitory substance, or anti-Müllerian hormone, which causes regression of the uterus. So if you have a Y chromosome abnormality with a disruption of the SRY gene, then you might not produce the normal amount of androgens, or you might not produce the normal amount of anti-Müllerian hormone, and you wind up with an individual who has ambiguous genitalia. So this slide also shows the many, many, many genes which are now known to play a role in sexual differentiation. Okay, so patients with Klinefelter syndrome are sometimes detected during prenatal screening, like I showed you, and they're sometimes detected by our pediatric colleagues in childhood and adolescence when they present with abnormal growth and development, or phenotypic abnormalities of small phallus, cryptorchidism, or when they have delayed puberty or small testes, breast enlargement, and other, most of which are neuropsychiatric symptoms, which I'll show you in a minute. As adult doctors, we frequently encounter Klinefelter syndrome because they have no sperm production, and they present to the gynecologist or a urologist with fertility, and ultimately they have a karyotype. They can also have phenotypic abnormalities, gynecomastia, osteoporosis, and other things as shown here. So the clinical features then of the Klinefelter Syndrome are infertility in nearly all patients, but not all, and I'll show you that in a moment. It's small testes, and I'll show you that in a moment. Azoospermia means no sperm. High gonadotropins, as in the initial cases. Mostly low testosterone, although you don't have to have a low testosterone level. Our man's level was in the normal range, if you remember. Frequently look hypogonadal with decreased facial hair, but not necessarily. Decreased pubic hair, but not necessarily. Breast enlargement, but not necessarily. And sometimes an undescended testis and a small phallus. In children, they, like I said before, learning disabilities are very, very common. Delay of speech development, psychiatric disturbances, autism, and other things. They can be tall. And I'll show you also interesting new ideas about the metabolic consequences of the Klinefelter Syndrome, with abdominal adiposity, the metabolic syndrome, osteopenia, the prevalence of type 2 diabetes, and the chance of having breast and mediastinal germ cell cancers. We've talked about examining the testes, Dr. Roman and I, and if you would look at our house staff medical records, no doubt you would find that the chances of having an exam of your testes when you're admitted to one of our unit hospitals is pretty small. The way to detect Klinefelter Syndrome most readily is to be suspicious based on the clinical phenotype and to examine the testes, which you do like this, by putting your thumbs together and your third fingers together and making a little bit of a cup, if you will, raising the testis from the scrotum like that, and using these fingers, the first finger sort of below the testis, feeling for nodules, and by putting your fingers at the ends of the testis, you can approximate it to a ruler, and a normal testis is somewhere between 4 and 5 centimeters in length. Physical diagnosis books would tell you if there's any evidence of inflammation, you should certainly use gloves in the exam, and many doctors use gloves all the time when they examine the testis, but not this individual. Here we have what's called a Prater oxidometer, which is a series of beads which just sort of simulate the size of the testes, and you can approximate the bead to the testis and say how many mLs the testis was. And in our case, I think I told you that it was 3 and 4, and a normal male was somewhere between 20 and 25. So this just shows the biventricular testicular volume. It should be between 40 and 50. And these are men with Klinefelter syndrome, so you can see that the biventricular testicular volume was somewhere about 4 to 6 mL, so 2 to 3 mLs per testis, but very, very small in comparison to normal. That's why it's so easy to make a diagnosis, because it's very, very easy to distinguish this from that. So the other thing then is to then do a endocrine evaluation. And you have a little bit of a more advanced schema of negative feedback here, showing how the brain regulates the pituitary, which produces the gonadotropins, which regulate testosterone and Sertoli cells respectively. There's negative feedback by testosterone coming from Leydig cells being converted to estradiol and inhibin, regulating selectively the production of FSH because of its effect to negate the activin receptor, which activin stimulates selectively the FSH-beta gene. Another little bit of information is that upstream of the GnRH neurons, which are the major regulator of the pituitary, are neurons producing kisspeptin, and these are the neurons really which are involved in negative feedback. Steroids don't directly affect the GnRH neurons. So what happens then is when the testes are damaged, as in the Klinefelter syndrome, there are fewer negative feedback signals, the GnRH production rises, these genes are turned on, and the levels of LH and FSH go up. When you damage only the sperm-forming elements, as in chemotherapy, which damages the germ-forming elements selectively, you make less inhibin, and when you make less inhibin, then you have inability to block the activin effect, and the levels of FSH rise. The levels of LH and testosterone are much less affected in the cancer patients. So when you found a man who looks hypogonadal, who has small testes, The next thing I do is measure testosterone and LH and FSH. And in a Klinefelter's patient, the testosterone is often low, but the gonadotropins are almost always high. So here's the normal range, and you can see the levels of LH and FSH far exceed the normal range. So it's pretty easy to tell that the patient has primary gonadal failure as a cause of the hypogonadism. And you can see that the total testosterone level range can overlap the normal range, so don't try to make the diagnosis of this syndrome or exclude it by measuring testosterone alone. You're going to miss a lot of cases. First of all, you're going to know something's wrong because you examine the testes. And if you find a very tiny testis, you know it can't be a man. Okay. Many of the Klinefelter patients do have breast enlargement, and some studies suggest that increased estradiol production, probably because of the increase in LH, is common, but in this series, the high levels of none were not. So this shows the levels of these hormones as an influence of age, starting at age 15 and going over. And here are the levels of LH. The Klinefelter's patients are in the solid squares here. And you can see that the LH levels, except for one man, are always very, very high. The only place you can get burned, I think, is someone who's extremely obese, because extreme obesity suppresses gonadotropin secretion. And you can have such extreme obesity, or you can have some other acute or chronic illness which is associated with gonadotropin insufficiency. So if you superimpose a second problem on the hypogonadism, you may wind up with someone who doesn't read the textbook, like this guy. But almost everyone else has a very, very high LH. And here you can see the testosterone levels. Many of them are in the normal range, although rarely do you see people who have high levels. One interesting thing is to look carefully at the men as they get older. So normal men have less testosterone as they grow older, shown here. But you can see among this group of men with Klinefelter syndrome, the older men, more than 40s, makes them very old, all have very, very, very low values. So probably there's a additive effect of aging and chromosome destruction on the Leydig cells, which really hasn't been explored. So, when you find a man who looks hypogonadal and has high gonadotropins, you of course measure a karyotype to see if he has Klinefelter syndrome, but there are many, many other explanations for primary testicular failure, and then you just go to your textbook and remind yourself of the differential diagnosis. An interesting one is myotonic muscular dystrophy. I saw such a patient not too long ago. And of course, people I mentioned will have acquired problems, testicular trauma, arthritis, spinal cord injury. You can have polyglandular or endocrine failure, retroperitoneal fibrosis and amyloidosis can sometimes affect the testes, et cetera, et cetera. So this is what the biopsy of a normal testis looks like. These are the seminiferous tubules. And this one is cut in cross-section, so it looks nice and round. And this one is cut longitudinally, so it's long, like that. And between the tubules are the interstitial or Leydig cells. And the Leydig cells make testosterone. The testosterone goes into the circulation. But testosterone also affects the nearby seminiferous tubules, the so-called paracrine effects. And testosterone is really a very fundamental spermatogenetic plant. As you look at the center here, you'll see little dark daggers. Those are mature sperm. And if you look from the outside in, the germ cells have a more and more and more mature appearance, and that's what a normal tubule should look like. It should be filled with cells. Here's a Klinefelter's patient. You can see the tubule is just filled with a scar. So sometimes this is called seminiferous tubular sclerosis. And here are the Leydig cells. You can see how hypertrophied they are, but it's a type of pseudo-hypertrophy because they're really not working that well. So somewhere there's a type of block in steroidogenesis, and I won't get into that as to how exactly I think that comes about. So almost all men with Klinefelter syndrome are azospermic, but a small number, here 4 out of 47, will have an occasional sperm. The normal sperm count is somewhere about 20 million per mil, or some say even 40 million per mil, and you can see that these men have less than a million per mil. But nevertheless, there are case reports of men having spontaneous fertility, and men who have some sperm then can be helped currently to have children with current IVF methods, and it's called testicular sperm extraction if necessary, and ICSI, intracytoplasmic sperm injection. So if there are sperm in the ejaculate, you can use that and inject them into the egg. Or a fancier way is to take the patient, the male, to the operating room, open the testes, do an open biopsy, and look around for a tubule that might look like that inside all of that scarring, and stick a needle into that tubule, pull out some fluid, and look around for a sperm, which you can then inject into the egg. And in experience centers, this works. This is an experience center, Cornell Medical Center. They have a very big IVF program, and they reported 54 men, many who have XXY chromosome constitutions, and of those having, somewhat a third or a half, ultimately having babies born. So Klinefelter syndrome also has extragonadal morbidities, and I wanted to bring that to your attention because this is something to be aware of, because it's something that an internist would be important in contributing to the health care of these patients. Among them are a high incidence of cancers, breast and mediastinal germ cell tumors, high prevalence of diabetes, both type 1 and type 2, thrombosis of the lower extremity veins with pulmonary embolism. These are all relative risk ratios above normal. A chance for having immune diseases such as lupus, having low bone mass with osteoporotic fractures, and maybe having other diseases as well. So how does this come about? Well, first, men who have Klinefelter syndrome are hypogonadal. So the hypogonadism is quite subtle, but nevertheless, hypogonadism has its consequences. So these are two twins, identical twins. One has metastatic prostate cancer, and he is becoming androgen deficient as a treatment for his metastatic prostate cancer with a generation analog, and he suffers then from androgen deprivation therapy. You can see his muscle mass has declined, and he's a whole lot fatter than is his twin. So no doubt many of you have read one of the many papers in the literature in the last couple of years about the potential adverse cardiovascular effects of testosterone treatment, mostly for men with the metabolic syndrome. But on the flip side of that is that when men are very androgen deficient, they're susceptible to having many, many complications. They have an increased fat mass, they have less muscle mass, they have decreased bone decay, which predisposes to adiposity, sarcopenia, perhaps insulin resistance, dyslipidemia, diabetes, the metabolic syndrome, the cardiovascular events, and falls and fractures. So hypogonadism and low testosterone may explain some of the morbidities that you find in Klinefelter patients. But remember also they have an extra X. So I showed you in the early slide with the bar body. So what happens is that one of the two X chromosomes gets inactivated. And that's shown here. One of the chromosomes being inactivated for each cell line. So this happens early on after fertilization, and it's sort of a random event, so that in the majority of women, there's about a 50-50 distribution of inactivation of the male-derived X and the female-derived, the mom and the pop, each contributed an X. Which ones get inactivated? Well, it's a random event, so it's most likely to be 50-50. But there's a big Gaussian distribution, so that some women will have mostly their father's X, and some women will have mostly their mom's X, hence the different phenotypes that women have versus their parents. Occasionally, you'll have very, very, very skewed. So once you have this type of inactivation, then it becomes clonal, and all the cells which are derived from that inactivated X have the same X inactivated. But it turns out that the inactivation doesn't inactivate all of the genes. So what happens is that soon after the fertilization in the early morula stage, this gene becomes upregulated, and it's called X-inactivating specific transcript, or XIS. And what that gene does is it recruits protein complexes which then silence most X-linked genes on one of the two X chromosomes. So here's what happens. Here's the, right here, X-inactivated gene, it exit, and you can see that it affects all of the neighboring genes on that X chromosome to silence them. But it turns out that 30% of the genes on the long arm, the P, but only 3% of the genes on the Q escape inactivation. So that basically men with Klinefelter syndrome have too many genes. And what could be the consequence of that too many genes? Well, this is the brain of a patient with Klinefelter syndrome, and they did that PCR, and they compared the level of expression of all of these different X chromosome linked genes in the Klinefelter's brain versus the normal brain, and you can see that there's marked upregulation of many, many different genes. So, what could that mean then? The Klinefelter syndrome phenotype may reflect 2 active copies of these strictly X-linked genes, or 3 active copies of an XY homologous gene. So if it's on the Y and on the X, you can see that these men have additional genes. So possibly the next step in the research in this part of the Klinefelter syndrome is to better understand these genes, to understand how they contribute to imbalance, to understand the downstream pathways that affect the phenotype, and maybe even giving us insight into breast cancer and germ cell tumors, etc., DVTs, which develop in the Klinefelter's patients. So one example of this is the tall stature. I showed you how tall the men with Klinefelter syndrome were. Mostly they have very long legs. So it turns out that there is a gene on the X known as SHOX, S-H-O-X, and it's believed to play a major role in growth. It's widely expressed in the limbs, and it regulates organogenesis. It functions as a transcriptional activator, and deletions and mutations of this gene are found in many children who have short stature of unknown etiology. It's associated with skeletal defects, and deletion of SOX on an X is the reason that Turner syndrome patients are very short. They're missing one X. If they're missing the short arm of the X, if they have a type of Turners where only the short arm is gone, they will be short. If they have a type of Turners where only the long arm is gone, they'll have normal height. And that's because the SOX gene is on the short arm. And it turns out that the more X chromosomes you have, the more of the SOX you have, and the taller you tend to be. So understanding the SOX gene helped them understand the growth phenotype of Klinefelter's patients. Now, while the patients tend to be tall, they tend to be overweight. And I showed you in that initial picture, you saw many of the men had a lot of central adiposity. So these are men with Klinefelter syndrome, and the open circles and the solid circles are the controls. And this is their BMI. Of course, you're heavier when you get with increased BMI. But you can see that the men with Klinefelter syndrome are always heavier for the same BMI than are the normal men. So the normal men here on this line, that's the regression line for the normals. This is the regression line for the... So at every BMI, you have an increased amount of fat in Klinefelter's patients. Maybe that's because of the androgen deficiency, or maybe it's because of some genetic difference in the X chromosome. And one wonders about the latter, because if you look at prepubertal boys, age 7 here to 12, way before they could be meaningfully androgen deficient versus the normal boys, you can see that they too are much fatter than are the average healthy boy, which would be along this line here. So what then is the consequence of having that central adiposity? Well, it's having a predisposition to the metabolic syndrome. So these are men from Japan, so their weight is a little less than where it used to. But you can see that the Klinefelter syndrome men are taller, just like in Caucasians, And the control groups here are men with obstructive vasospermia, mostly men who had vasectomy. So that's from the urology group, I think. So they're trying to control for the fact that the men haven't produced no sperm. And the non-obstructive vasospermia are men who have vasospermia, but they don't have Klinefelter syndrome. They have some other reason, for example, a Y chromosome deletion. So that's the controls. So you can see the Klinefelter patients have a much bigger waist than either of the other groups. You can see that they have a higher LDL and a lower LDL, and the chance of having the metabolic syndrome by these criteria is much higher in the Klinefelter syndrome males than in either of those controls. So here is the chance of having the metabolic syndrome. I think this is from Belgium, maybe, somewhere in Northern Europe. And you can see that the chance of having the metabolic syndrome in the Klinefelters in their group was nearly half, versus the controls down here about 12%. And the same was true with having diabetes, it's much more common, and having impaired fasting glucose is much more common, and this is either or. So you can have central adiposity, obesity, metabolic syndrome, and diabetes much more often. Maybe it has something to do with the androgens, because when men who are treated with testosterone are compared with Klinefelter syndrome patients who are untreated, their weight is less, their BMI is less, and their waist is less. But in this study, none really of those differences was statistically significant. Another abnormality is low bone mass. Here's a group of Korean men with Klinefelter syndrome and controls. Once again, the Klinefelters are taller. Of course, they have much lower testosterone. These are untreated men. And the Klinefelter syndrome patients are heavier. If you look at their bone mass, this is a Z-scores here. You can see that the Z-score, osteoporosis score, is much lower than in the controls in the lumbar spine and in the hip and in the Lorient's triangle. So all of these are very highly statistically significant. So men with Klinefelter syndrome also have low bone mass. And here the men with Klinefelter syndrome were divided into two groups, those who had a low testosterone level and those who had a level of testosterone in the normal range. These were a little older, they were a little heavier, they had a higher BMI, they had a higher waist circumference, they all had high gonadotropins. But there really wasn't any difference in the bone mineral density between these two groups, leading these authors to propose that the predisposition to low bone mass is maybe partly from the sex steroid abnormality, but also may be from a genetic perspective. I mentioned before that there are a lot of genes which seem to be overexpressed in the brain in Klinefelter's patients. And I mentioned before that Klinefelter's patients often present to pediatricians, and they often present to pediatricians because of their learning disability. Their chances of having ADHD, 63%, of having autism, depression, anxiety disorder, other psychiatric disorders, and even schizophrenia and all of that. So the chances of having some sort of neuroendocrine type of abnormality in Klinefelter patients is very, very high, and this is unlikely to have anything to do with sex hormones because it usually presents itself in childhood and adolescence. I thought this was especially clever. This is a study from Korea where they looked at the outcomes, what exactly the men with Klinefelter syndrome do. And here they talk about their education. So here are the men who went to high school who had Klinefelters, or finished junior high school, or had vocational college, university, or graduate degrees. So you can see that the chances of having a university or graduate degree in the Klinefelter syndrome was less than 25% versus nearly 3/4 in the control. And I thought this was so clever because they did a sibling control. I always try to do a sibling control when I do a patient, because it controls for all sorts of other genes that are shared by the siblings. The siblings don't have Klinefelter syndrome. You can see that the siblings have the same chance of going to a university or graduate school as do the controls, and they vastly exceed the likelihood of these events in Klinefelter patients. So basically, even though their IQ isn't very different from normal, they just don't seem to succeed in the educational environment. And maybe this has something to do with testosterone, I don't know, because there aren't really any controlled trials. But this study would say that the men who were testosterone treated were more likely skilled laborers and than the untreated men, whereas among the unskilled laborers, the untreated were much more frequent than the treated. And then, same way, how many view themselves as well-adjusted in the testosterone-treated group versus the untreated group, and how many had a satisfactory view of themselves, 14% in the, unsatisfactory view, 14%, and in the untreated, 44%. So there really aren't any controls. Men with Klinefelter syndrome are treated with testosterone, and all of the outcomes which I have shown you and described and talked about are all intuitive, and you'll find many statements like this. Oral testosterone replacement results in increased masculinity, strength, libido, bone mineral density, and body hair. It has a positive effect on mood and behavior, improves goal-directed thinking, self-esteem, reduces fatigue and irritability. Early recognition and treatment of Klinefelter syndrome can significantly improve the patient's quality of life and prevent serious consequences. When testosterone serum concentrations in patients with Klinefelter are low, lifelong substitution therapy is indicated and should be started as early as possible to avoid symptoms and sequelae of androgen deficiency. We suggest initiation of testosterone treatment at the beginning of puberty as LH and FSH start to rise to secure a proper masculine development of sexual characteristics, but also to secure a sufficient increase in bone mineral density and muscle bulk to prevent subsequent osteoporosis. And this last one described reminds me of a patient I had in Pittsburgh whose father was a doctor and was sure that this was the right thing to do and would chase the son around with a syringe filled with testosterone to try to give him injections, and the son didn't want his injections. He was 12 years old, and there was a big issue between the son and the father, with the father feeling this way, and the son wanting nothing to do with testosterone injections at his point in life. That really happened. So how do you decide how much testosterone to give? When we treat people with hypothyroidism, we use TSH as the endpoint. The goal of restoring euthyroidism is to suppress the TSH in primary hypothyroidism into the normal range. That doesn't seem to work for hypogonadism because men with hypogonadism are resistant in a way to steroid feedback. So what we did here was measure LH. We were doing studies of pulsatile secretion to understand LH pulsatility, and we admitted individuals with Klinefelter syndrome and normals to our NIH Clinical Research Center, and we did a whole bunch of tests on Monday and gave them an infusion of steroids which gave them normal values and repeated all the blood tests on Fridays. And we compared them Monday and Friday in this experiment. So you can see that the ability of androgens to decrease the LH and FSH is much greater in the normal individuals than in the hypogonadal men, whereas the estrogen effects are really much more similar. And I call this a type of androgen resistance and primary gonadal failure. And now we know the reason for this is that the testis produces inhibin. Inhibin regulates the GnRH receptors, and when you have testicular failure, the number of GnRH receptors is markedly increased. And by giving testosterone treatment, you don't affect that. So that it's more difficult to suppress LH and FSH. And if you do so, if you're able to give enough testosterone to suppress LH and FSH, it means you're giving a whole lot of testosterone. I saw such a patient 2 weeks ago. He had no LH or FSH in his blood. He had like 3+ edema of his lower extremities. And I did his urine analysis. I got the chem profile. I did all the things, listen to his heart and all of that to try to figure out why on earth he should have all that edema. And I didn't come up with anything. And I talked to him yesterday, among rounding and all the other things I had to do yesterday. And I had reduced his testosterone treatment by 50%. His edema's gone. So you don't want to have low LH and FSH in hypogonadal failure. Instead, you want to look at the testosterone level, which is not so easy to accomplish, mostly because of the pharmacokinetics of the testosterone preparation. So here, in the broken lines, is the standard treatment, injections of testosterone and amphane, which are given intramuscularly every 2 or 3 or now sometimes even 1 week. But what happens is in a day or two after you give the injection, the values go up a lot and then it decays. So which value do you look at to decide if the guy is being treated normally? There's even a preparation that lasts now 90 days. It's called testosterone undecanoate. You can see, once again, you have a big decay. Oral androgens, or oral testosterone undecanoate, is given twice a day. And you can see how big the peaks are and how difficult it would be to figure out what's normal. And this is one of the reasons why the testosterone gels have become popular, at least among physicians, because the relatively stable levels of testosterone which are produced by the gels. So, in summary then, Klinefelter Syndrome results from an additional X, producing a 47XXY chromosome constitution. It's the most common sex hormone disorder. It affects 1 or 2 people in every 1,000, and every one of you knows someone with Klinefelter syndrome. But many patients with Klinefelter syndrome are not diagnosed. They'll often present with adult doctors with infertility, but many patients with infertility don't seek medical attention. All the men with Klinefelter syndrome have small testes, perhaps up to 6 mLs in the orchidometer, and this is evident during puberty and in adult life. So you can diagnose your patients with Klinefelter syndrome if you include the testicular exam in your routine physical exam. The testosterone levels may be normal, so don't use that to exclude the diagnosis. Most genes from the extra X undergo an activation, but some escape and may be the cause of the testicular failure and many of the other complications of Klinefelter syndrome. I showed you that metabolic syndrome is common in Klinefelter syndrome and predisposes to diabetes, that the quality of life is reduced, that most authors suggest beginning testosterone treatment at the start of puberty, but there are no randomized trials to allow definitive conclusions, and the impact of this treatment on future fertility, which I didn't get into, is controversial. Not all men with Klinefelter syndrome are infertile. You can occasionally find sperm in the ejaculate, and even among others, the testicular sperm injection and IVF allow for infertility in maybe 15% of the cases. And the most important thing is to develop an interdisciplinary collaborative team with pediatricians, endocrinologists, urologists, geneticists, and psychologists to do lifelong medical management of Klinefelter patients, the type of integrated care which we only theorize here in the U.S., but I think over the years it's going to probably advance. So thanks very much for your attention. I hope you found this interesting.
Thank you so much, Steve. This was really interesting to me, because this is not an area that I think about a lot. And I learned a lot about this today with your excellent presentation. I was mostly intrigued about the many effects that this disorder can have that you can't quite explain by hormonal alterations. And it suggests to me that this is a great opportunity to identify potential genes that are relevant to atherosclerosis and osteoporosis and height and all that kind of thing. Are there any other than that SHOT gene or the CHOPS gene that you mentioned? Are there other genes that people are trying to identify that relate to this that might be intriguing?
Yeah, well, yes. I mean, especially in cancer, we try to understand why one gets gonadal germ cell tumor. I found several papers which have looked at the X chromosome genes which might predispose to those tumors. And in the CNS, I showed you the list of genes which are all being studied and how they may relate to personality and behavior in Klinefelter patients and in the general population. So yes, but I don't think there's anything yet which is as well established as is the growth effects of the SHOT gene.
The other thing that was intriguing was that you mentioned, was it in Denmark that they do such genetics on all these kids as soon as they're born? Considering or not considering costs, it seems to me that will be quite helpful, particularly since we have a country that is already doing this, who have figuring out all the ethical issues that come by using that information. What do you think about that?
Oh, I think it's very important. I mean, these are the impediments that we have because of the reducing NIH budget. There are many centers which are already recruiting patients, doing obtaining either tissues or blood cells and looking carefully at doing a genome-wide study, looking for all the potential genes, putting that together with all their illnesses, pulmonary fibrosis, and all the many other things which you can do if you have the funds to do it. We have, in the U.S. we are plagued by the business of medicine and how organizing and integrating a program like this is easier in Europe, where the health care is all run and financed by the state. And here we have to apply for grants and hope we can put together an integrated team with all who know what they're doing and could make a compelling case for doing just what you're saying. But in many centers throughout the country, this is exactly what's happening, often from specific perspectives. But nevertheless, they have all of these banks of information, which then the people interested in bioinformatics can start to mine all of those things. And I think even now you see, if you read the journals, the type of material being published in the JCI or other papers is quite different than it was 10 years ago. And you see just that, genotype-phenotype correlations.
Great question. So, why don't you repeat the question?
The question is if the maternal origin of the chromosome is from the mother, or if the Klinefelter syndrome really has a paternal origin. Does that have an impact on any of these outcomes? I'm not enough of a geneticist to read that literature that carefully, and I can't really answer that.
I think it's, the presentation-wise it's so variable. I think there's a difference, because why I'm asking this question is that gene binary interaction is really kind of influence the dysfunction. So I think the chromosome from father in the male system and the chromosome X from mother in the female system, and they have a different gene in environmental interaction. And so it comes to the baby, probably they behave very different. So that's why